Hello, everyone, and welcome to our webinar, Neonatal Abstinence Syndrome Clinical Practice Guidelines 2016. My name is Doreen Day, and on behalf of the Provincial Council for Maternal and Child Health, I would like to welcome everyone to the webinar. Before we get started, given our large attendance, at this time, I'd please ask everyone to mute your phones if you're on a phone. If you're watching through your computer, you should already be muted, so if you're on a phone, if you could just mute, that would be great. We will have an opportunity for questions at the end of the presentation, and there will be two ways for you to ask the questions. You can either use the chat box function on your screen, or you can email your questions directly to me at doreen.day@pcmch.on.ca. In addition, we will also be live tweeting the session, so we encourage you to do so as well. You can use the hashtag NASGuide2016. For our webinar today, it will be given by Dr. Alice Ordine. Dr. Ordine is the Medical Director of the Toronto Centre for Substance Use in Pregnancy at St. Joseph's Health Centre and Associate Professor in the Department of Family and Community Medicine at the University of Toronto. Dr. Ordine received her Doctor of Medicine and Certification in Family Medicine at U of T, and also completed a Master's of Health Science in a collaborative program in alcohol, tobacco, and other psychoactive substances from the Department of Family Medicine and Community Health at U of T. Most recently, she has received her certification in addiction medicine from the American Board of Addiction Medicine. So without further ado, I will turn it over to Dr. Ordine to begin her presentation.
Thank you, Doreen. And I'll get started just to give you a brief agenda for the webinar. The first part will provide some background and an overview of our initial work and highlight some of the key changes in the updated guideline. And this will be followed by a presentation of the current guideline summary and then discussion. I hope we have lots of time for questions, so I think we should be able to get through this material to allow for a fulsome discussion. So as most of you are aware, we are having an opioid epidemic. So we have data from national surveys, such as the Canadian Tobacco, Alcohol, and Drug Survey, which revealed that the rate of past year use of opiates among the general population was approximately 15%. And 2% of these opiate users were actually reporting past year misuse of opiate pain relievers. So it's not surprising that Canada is having a large epidemic now, and we're following the US, which has reported past year prevalence of non-medical use of prescription pain relievers at 4%. Specifically in Ontario, we've been ranked as the highest rate of narcotic use in Canada. In pregnancy specifically, we have very little Canadian data about the prevalence of opiate use, but we do have some data again from the US. This is from the 2014 National Survey on Drug Use and Health. In this survey, they found that 5% of pregnant women reported illicit drug use in the past month, 0.2% reported heroin use, and 1% non-medical use of prescription opiates. So as you can imagine, we're dealing with actually a substantial population of pregnant women using opiates ongoingly throughout pregnancy, and then the results in NAS that has to be dealt with afterwards. We are worried about opiate use during pregnancy for several reasons. It leads to negative pregnancy and neonatal outcomes. There's been documentation of premature delivery, even early miscarriages, intrauterine growth restriction and low birth weight, neonatal abstinence syndrome, which is what this webinar is about, and other possible adverse long-term effects. To give you a definition of NAS, it's a syndrome. It's a constellation of symptoms and signs in newborns, and this is a result from an in-utero exposure to drugs, specifically in this case, opiates. This is presenting as neurological, gastrointestinal, and respiratory symptoms. Most commonly, you will see high-pitched cries, exaggerated startles, increased tone, poor feeding, vomiting, loose stools, and a failure to thrive. We know that with regular maternal drug use during the last 2 weeks preceding birth, this is a risk factor for NAS, and those are the infants that will specifically need to be observed for NAS. The incidence of NAS in Canada has increased significantly. We know that currently 3.8 infants out of 1,000 births to mothers who were using opiates during pregnancy displayed withdrawal symptoms. In Ontario, the incidence of NAS has increased from 0.9 infants to 5.1 infants out of 1,000 births. This represents a 4-time increase in the prevalence over this 10-year time period. So again, a very worrisome trend. This graph looks at the rate of neonatal abstinence syndrome over the last 5 years. In 2009, Ontario, which is the blue line, surpassed the national average, and this is continuing to be the trend for the last 5 years. So again, those of us who practice Ontario have a reason to be worried. The impact of NAS is both at a personal and a system level. So for these infants, they have a prolonged length of stay in the hospital for specialized care, and they also need support both for the infant, but also the mother and the family. There's increased utilization of scarce resources in the level 2 and 3 neonatal units. And there's also a lot of long-term possible developmental and psychological problems, which means, again, that we need more support from healthcare, social services, and the education system. Another way to look at the impact of NAS, again, is utilization of beds per day. And if we look at this graph in the last 5 years, we see that as the number of infants with NAS has increased, more beds are also being utilized for management of NAS and for treatment. And recent estimates suggest that anywhere from 3 to 4% of neonatal beds are occupied by infants diagnosed with NAS. So for these reasons, in 2010, there was a need to put together recommendations for the management of NAS. So in May of 2010, a provincial task force was convened, and this was of experts in clinical care and social support of pregnant women and high-risk infants. Our work started with conducting an environmental scan to see what the current practices were at the time across the province and hospitals. We then performed a literature review, and we summarized recommendations for harm reduction strategies and the optimal management of NAS. Now, the scope of the original recommendations was limited to NAS resulting from opiate dependence, and this ranged from recommendations from preconception to antenatal and postpartum strategies as well. In 2016, we felt that there was time for us to reassess the literature since 5 years had passed since the original work was done. And this seems to be a new standard of care for most national guidelines to be revised every 5 years. And we thought it was time to provide an update. In doing this work, we were able to streamline and condense our recommendations. Again, this is in keeping with other national and international guidelines. We updated the references to support the original recommendations and expanded a list of resources. And the biggest change probably was the removal of routine toxicology testing recommendations. We felt that there was a lack of clear evidence that this was helpful, and also the time delay in getting results specifically from meconium and hair samples that we felt they did not impact clinical management, and therefore we made this removal. So let's start going through the current guidelines from the preconception aspect. So as we mentioned, the bulk of our work was focused on antenatal care and postpartum, but we wanted to also highlight a few key points in the preconception time period. It is recommended that primary healthcare providers screen all women of childbearing age for use of listed and illicit substances as part of a routine health history. So again, this emphasizes screening by history taking. We know that if we can identify these women earlier, we can also implement strategies to make a difference in their outcome. And screening should be comprehensive. Again, women typically use more than opiates, and that's why we want to catch all substances of potential harm. If someone ends up providing a positive self-report, then that is an indication that they need a further assessment, whether that's done through using a more validated screening tool or referral to a comprehensive evaluation by a specialist such as an addiction medicine specialist. It all depends on local resources. Now, opiate abuse typically suppresses ovulation and it can affect menstruation. And therefore, women who are identified to have an opiate use disorder should be educated about the risks that discontinued opiate use may have on their future reproductive health. When women are starting opiate maintenance treatment with medications such as methadone and buprenorphine, they should be routinely counseled about contraception because starting this treatment can actually resume ovulation. And therefore, if they have the opportunity to have contraception counseling in advance, this will minimize the risk of unplanned pregnancies and therefore reduce the incidence of NAS as well. Antenatally, the recommendations still stand that healthcare providers should routinely screen all pregnant women for the use of opiates and other listed and illicit substances. Again, we recognize that pregnant opiate users also frequently report alcohol, tobacco, and other substance use. In addition, every pregnant opiate-using woman should be offered comprehensive care. So this means obstetrical care, addiction care, psychosocial counseling support. It really is dictated by the local community how this is achieved. It could be all in one location or several providers working together as a team. We know from recent evidence from a meta-analysis that women who are engaged in integrated care programs do have improved maternal and neonatal outcomes, such as more prenatal visits, fewer positive urine drug tests, and fewer birth complications. And that's why this recommendation is evidence-based and should be implemented based on your local resources. We also wanted to promote anticipatory guidance. We know because of the complexity and the unpredictability of NAS that every pregnant opioid-using woman and her partner and or family should receive written materials explaining NAS, the hospital stay expectations, their involvement in the care of their infant, and other resources in their community. This is vital to helping the woman and the partner prepare for the NAS experience. When we deal with management of the actual opioid use disorders during pregnancy, methadone maintenance treatment has been the standard of care for the management of opioid use disorders for women who are pregnant. And that is based on numerous randomized trials performed dating back to the 1980s and 90s. We have some more recent literature from a randomized controlled trial called the MOTHER study, which has promoted the use of buprenorphine maintenance treatment as an alternative to methadone for the management of opioid use disorders in women during pregnancy. And this can be considered, especially in communities where methadone may not be available. And if methadone or buprenorphine are both not available, then other sustained release preparations may be considered for the management of opioid use disorders in pregnancy. And we realize that geographical differences, especially in regions of Northern Ontario where there may be scarce resources, alternatives to methadone and buprenorphine need to be considered and made available. Now, women with opiate agonist treatment and opiate use have very complicated lives and they have multiple psychosocial needs. However, referral to Child Protection Services, or CPS, should be considered on a case-by-case basis. So pregnant women who's on methadone or buprenorphine, that's not itself an indication to get CPS involved, but it should be looking at their complete social picture as well. The women who are on opiate agonist treatment should also continue on this medication while they're in labor to prevent withdrawal. In addition, medications for pain management will be needed during intrapartum period. We know that short-acting opiates have been shown to be effective for both intrapartum and postpartum pain in opiate-maintained women, and this should be readily offered. A discussion about CPS, or Child Protection Services, can be also considered antenatally, and this may enable for a decision to be made about the indication to get CPS involved. However, it shouldn't be just routinely considered. And just as a reminder, women who are on opiates on a regular basis should not be given any narcotic antagonists, since that can prompt immediate withdrawal for both the mom and potentially for the baby, depending on administration during the labor process. We also want to promote a partnership plan. And this partnership plan should be between the care providers and the parents, and it focuses on all aspects of infant care, including feeding, handling, rooming in, frequency of follow-up visits. And this will help support the parents specifically in involving them in the care of their infant. So we have provided the sample prenatal specialized care plan that we implement at St. Joseph's Health Center where I work. The goal of this care plan is to identify the care providers on the first page, and at the bottom we list the specific issues relevant to that pregnancy and the suggested management plan. This includes both medical and social history taking. So for example, there's an area there where we indicate whether Child Protection Services are involved and what's the expected outcome if we know it antenatally. This plan is also created in partnership with the patient, and she's involved in creating it, and she's also given a copy of this plan if she would like to have one for herself, but it's not a secret. It's something to promote the patient's well-being and to help the teams, the various team members involved in her care. The second page of this care plan is actually recommendations for management during labor, postpartum, and discharge plannings. It talks about what are the expected plans for methadone during labor, what is her pain management preference, what's going to happen with the baby once it's born, what are the plans for breastfeeding, and this also prompts discussion points antenatally. So these are all areas that should be addressed with the mom before she gets to the intrapartum part. This care plan then is reviewed by the care team when she's in labor. This includes the maternity care provider, the nurse, the social worker, and it facilitates communication among the various team members and also on-call team members if it's not the same provider that's providing the antenatal care and the intrapartum care thereafter. So moving on to the NAS screening recommendations. So identifying infants with NAS is critical for timely and effective treatment, and this identification should be based on the mother's antenatal history preferably and the care provider's clinical assessment and suspicion. Sometimes it becomes more apparent after delivery, but ideally it's an aspect of the history that is provided while the woman is pregnant. It also recommended that a standardized NAS scoring tool is used to assess the in utero opioid exposure. So a scoring tool, a standard scoring tool, is usually a systematic, objective, and periodic assessment of the newborn. So this allows you to, it's designed to quantify the severity of NAS. Now, this scoring tool should be implemented within a couple hours of birth and then repeated regularly thereafter, usually every 2 to 4 hours. Depending on the half-life of the opiates that the mom was using, the duration of observation will vary. So for example, in the case of exposure to short-acting preparation of opiates, such as oxycodone and morphine, infants should be scored for a minimum of 72 hours. In the case of exposure to sustained-release preparation, such as methadone, buprenorphine, the observation period would have to be extended for a minimum of 120 hours, since the onset of withdrawal may be delayed. While this observation period is ongoing, mother-baby diet care should be promoted, and this is depending on, again, local resources, whether it's rooming in or care by parent. And we have literature, again, from actually a Canadian study that has shown that rooming in is associated with a reduced need for pharmacological treatment and a shorter length of hospital stay. So here's an example of a standardized NAS scoring tool. In the last version of the guideline, we refer to this as a modified Finnegan scoring tool. But I think with the follow-up revisions of these scoring tools, it is now recommended to be called a sample standardized NAS scoring tool. Again, this is to determine the severity of the symptoms and to guide treatment and weaning in the full-term infants. This scoring tool comes with instructions as well as clear descriptions of how to score each parameter. And then there's also a protocol which outlines treatment with medications. So to go through this data flow sheet, it provides a little bit of an organized approach to these infants. So again, starting with identification of these newborns at risk of NAS. If there is a concern, using the standardized scoring tool to evaluate them from within 2 hours of birth and then regularly every 2 to 4 hours. If the score remains less than 8 and it's low, then the infant can be considered for discharge. However, if the score starts to be increased, then ongoing assessments required. And as we'll mention shortly, as the score is escalating, then treatment is required with pharmacotherapy. And then depending on social risks or not, then the infant can either be weaned from morphine in the hospital or at home. And we'll talk about this shortly, what would be the required criteria. It's important to realize that newborn treatment recommendations encompasses both non-pharmacological and pharmacological interventions. We do promote that non-pharmacological interventions should be utilized in all infants with NAS, and then in a smaller subset, pharmacological interventions may be needed if NAS escalates and the non-pharmacological interventions just do not ameliorate those signs of withdrawal. So to talk about the non-pharmacological treatment options first, so for all babies who are at risk of NAS, the environment should be modified to reduce sensory stimulation. And this can be done by limiting visitors, minimizing overhead lighting, and reducing noise. In addition, soothing behaviors, positional support, swaddling, and gentle handling may also be beneficial to reduce NAS, and this is important both in the hospital and the home environment. This is also important to help infants with transitioning between their neonatal behavioral states. Smaller, more frequent hypercaloric volume feedings are also beneficial. This is specifically in infants with feeding difficulties and those failing to thrive in having difficulty gaining weight. So all of these non-pharmacological interventions should be routinely offered for all infants. Breastfeeding is also recommended and supported in women on methadone and buprenorphine, and that's assuming that there's no other absolute contraindications such as ongoing drug use. There's numerous studies that have indicated that breastfeeding and breast milk intake may be associated with reduced NAS and a decreased need for pharmacological treatment. These studies are still in their early days, but there is promising evidence which has prompted this recommendation. And also, it's very important to remember preventative skincare for infants to prevent excoriation, since they're prone to skin breakdown due to frequent loose stools. So interventions such as frequent diaper changes, the use of barrier creams are also very important. Once pharmacological treatment is considered, it's important to go beyond supportive care measures. Experts felt that cardiorespiratory monitoring was recommended for all infants starting on morphine and continued for 4 days or until the dose is reduced. Further monitoring that would be at the discretion of physician who's treating the infant. Even though there's a lack of concrete evidence around this recommendation, the experts involved in our group felt that this should be recommended routinely. Now, for cardiorespiratory monitoring, this may be done through either admission to a special care nursery, an NICU, or a pediatric unit, again, based on your local resources. So from numerous trials, morphine is considered the first-line pharmacological treatment of NAS when supportive measures fail to adequately improve withdrawal. And for infants who are difficult to control despite higher doses of morphine, then additional medications such as clonidine and phenobarbital may also be required. There's very little evidence on the use of these adjunctive treatments. There's one study looking at the benefit of clonidine and another one comparing clonidine and phenobarbital, making clonidine more favorable over phenobarbital, but more studies are still required. Phenobarbital has been promoted in women who may have had polysubstance exposure, such as those using opiates and benzos or barbiturates. But again, it may depend on your local protocol, which adjunctive medication you would be adding to morphine. Now, in order to transition these infants and to make sure there's no gaps in care as they are going into the community, it is important that primary healthcare provider who is comfortable to follow these babies is identified prior to discharge. And they should be confirmed that they are comfortable following their growth, their development, and providing other reassurance to the parents. Once the baby is stabilized on morphine and discharge planning starts to become an issue, the weaning process can also be considered in the community. However, there has to be sort of stringent criteria followed for this to be an option. So this sounds a little bit rigorous, but it does require all of these criteria to be in place before a baby could be discharged from medications. So a baby who's on morphine and the team has deemed that the social risk is low, they could be considered to be weaned at home if there's a designated supervisor identified again in the community, and this person would be following the infant at least with weekly visits and be readily available to answer any questions that the care providers have. And in some communities, this is the standard of care. However, if these criteria cannot be met, then the infant would have to continue being weaned off morphine in the hospital setting. In the end, after consultation with the clinical team, the final decision to discharge an infant on pharmacological treatment would be at the discretion of the physician. Now, we also know from the literature that infants with prenatal opiate exposure have also found to be at risk for cognitive and psychomotor deficits, and therefore it's important that every baby exposed to opiate agonists and other substances should be offered ongoing developmental assessments by a clinical expert. Again, based on your local resources, this may be a pediatrician or be done through natal follow-up clinics or arranged in other means. But it is important that these infants are followed in the long term for both growth and development. So then to summarize, narcotic use in Ontario is continuing to increase and so are the rates of NAS. Prevention of unplanned pregnancies is important to influencing the incidence of NAS. Pregnancy is definitely a window of opportunity. Women are very motivated to make a change, and we know with methadone and buprenorphine maintenance treatment, we can help them to prevent relapses, stabilize their social risk, and improve outcomes both for them and their infants. We also have to remember to support families to end up with the optimal management of NAS, since that is a very important component of NAS care. So the physical components of NAS are treatable. We have protocols for managing that. However, the most challenging part of working with infants with NAS still remain the psychosocial factors. So making sure that we are addressing all various aspects from housing safety, financial issues, et cetera, and that the family is supported while they're in the hospital and then ongoingly in the community setting. So I hope the recommendation that were produced by our working group provides a framework to reduce both the incidence and impact the treatment of NAS, through implementation of prevention strategies of at-risk infants, and also provides you with standardized treatment recommendations for both maternal and neonates. And the full guideline is available on the PCMCH website. And we also have included on the PCMCH website a sample treatment dosing guidelines for anyone who wants to have a look at that in more detail. And we want to acknowledge the various group members that have contributed to this work back in 2010. And then those of us who've worked on this in 2016. There were 3 of us from the original group, myself, Kim, and Henry, and we had Christina Canton who joined us on the updated version of the guide.